So good morning, everyone. We'll be starting our e-poster session on the community and comprehensive social ophthalmology. The first presenter for today is Dr. Tusi Molsum. She'll be presenting on clinical profile and visual outcomes of patients with lens-induced glaucoma. Over to you, Dr. Tusi.
Good morning, everyone. My topic is clinical profile and visual outcomes of patients with lens-induced glaucoma. My aims and objectives are to study the clinical profile and visual outcomes of patients with lens-induced glaucoma. Materials and methods. In this, the study design is a retrospective analytical study, and the source of data were patients attending ophthalmology OPD in Chamarajanagar Institute of Medical Sciences, and 14 cases of lens-induced glaucoma who attended the OPD between June 2023 and November 2023 were included in this study. And patients with elevated IOP, lens-related issues, hypermature cataract showing classical signs like pain, redness, and corneal edema were included in this study. IOP was measured using Goldman applanation tonometry, and visual acuity was assessed using Snellen's chart. Treatment included oral acetazolamide, topical anti-glaucoma medications, and steroids with IV mannitol for IOP over 40 mm of Hg. After stabilizing IOP, all patients underwent small incision cataract surgery, and exclusion criteria were primary glaucoma, inconclusive data, and follow-up under 2 weeks. Data was analyzed using SPSS 20.0. And the results were females were majority in this study, that is 9 of them were females and males were 5 of them. And mean age was 67.71, in which there was equal distribution between all the age groups except for 75 to 80 years. And mean IOP was 40.58, in which maximum of them presented between the IOP of 40 to 45 mm of mercury. And phacomorphic glaucoma was seen predominantly in this study, followed by phacolytic. And the presenting symptoms were diminution of vision and eye pain were present in all the 14 of them, and swelling of lids in 10 of them, and redness of eyes in 11, headache in 9, nausea in 3, and vomiting was complained by 1 patient. And presenting signs were circumcorneal congestion, corneal edema, and mid-dilated pupils seen in all of the patients, and AC reaction in 12 patients, shallow AC in 10, and there was no fundus visibility in any of the patients. In final BCVA, we can see in post-op visual acuity 6/24, visual acuity was seen in 4 patients, and 6/36 in 4 patients, and 6/60 in 3 patients. BCVA at 6th week was 6/9 in 1 patient, 6/12 in 3, and 6/18 in 4 patients. Patients who presented with IOP of 40 to 45, majority of them had BCVA of more than 6/18, and which was not significant. In discussion, the results of this study indicate that phacomorphic glaucoma is more common than phacolytic glaucoma. Similar results were seen in studies conducted by Payal Gupta et al. And Sharma RG et al. And our study have shown BCVA of 6/12 or better in 28.56% of the patients at 6 weeks, which is comparable to Gupta et al., who had 24%, and Pradhan et al., who had 31.4%. In conclusion, I would like to say that early diagnosis and treatment of cataracts are crucial to prevent lens-induced glaucoma, and health education on regular eye checkups and timely cataract management is crucial for preventing LIG. And community outreach programs such as eye camps not only raise awareness but also facilitate access to necessary treatments, contributing to better overall eye care and prevention of complications. These are my references. Thank you so much.
It was a nice study, Dr. Tusi. I would like to just add one point. Yeah, okay. Whatever you mentioned in your conclusion slide, usually in the rural setup areas, patients presenting to the hospital itself will be very late, and yes, both of them will be presenting with a mature cataract.
Yes, ma'am.
One of the eye will be operated and they'll be better with that.
Exactly.
The other eye will be lame, they will just ignore, they'll just carry on with that, the better vision. So we'll just need to counsel them. But though the other eye also might go into this kind of another complicated kind of cataract, and we need to avoid to reduce the LIG due to phacomorphic glaucoma.
Yes, ma'am.
It was a nice question.
Thank you so much.
Thank you. The presenter ready for presenting. Your good name, doctor? Please. On changing trends of epidemiology of retinopathy.
Thank you, ma'am. Good morning, everyone. I'll be presenting on the topic. As we all know that retinopathy of prematurity, it is a retinal vascular disease that usually affects the premature infants in whom the retinal vasculature is not fully developed at the time of birth. It is considered as third epidemic in India and other similar middle income countries, and a global initiative has been taken for elimination of avoidable blindness. The ROP, the trend has been increased because of increased rate of premature births, compromised neonatal care, and lack of screening and treatment programs. For this study, informed consent was taken. There is no financial and sponsorship. There is no conflict of interest, and the aim of the study was to find out the epidemiological changes in retinopathy of prematurity in tertiary care center of Northeast India. It was a prospective observational study which was done in NICU of Guwahati Medical College and Hospital from June 2022 to 2024, which included 1152 infants which were admitted in Department of Neonatology. That fulfilled inclusion and exclusion criteria. Inclusion criteria included all the infants, birth weight of less than 2000 grams, gestational age less than 34 weeks, and infants with age group gestational age of 34 to 36 weeks with comorbidities like apnea of prematurity, prolonged oxygen therapy, cardiorespiratory support, and intraventricular hemorrhage. And the loss to follow-up cases were excluded, and all the infants with weight less than more than 1500 grams and gestational age more than 32 weeks with no history of cardiorespiratory support, ventilation, long duration of oxygen therapy. Detailed maternal history was taken. Initial examination, it was done not more than 4 weeks of the birth, and the pupils of infants, they were dilated using fixed combination of 0.4% of tropigamide and 2.5% of phenylephrine drops. The screening, it was done by trained ophthalmologists at NICU under supervision of pediatrician after instilling 2% proparacaine drops using lid speculum, using binocular indirect ophthalmoscope and 20D lens and a scleral depressor. The babies, they were diagnosed with ROP the baby diagnosed with ROP were classified according to the international classification of ROP, and they were followed up till 40 weeks of postmenstrual age or till retinal maturation was complete. So in our study, we saw that out of 1152, 42% babies, they were born with between age of 30 to 33 weeks. Less than 40% were less than 30 weeks, and 18% were more than 34 weeks. And they were screened, 1152 infants were screened for ROP. They had a birth weight of less than 2500 grams in 37% patients, in 14% patients less than 1500 grams, in 3% the birth weight was less than 1000 grams, and 46% they had a birth weight of more than 2500 grams. Also, the associated comorbidities, hyperbilirubinemia, it was seen in 16% of cases. Respiratory distress syndromes, it was seen in 10% of cases. And oxygen supplementation, it was given to 23% of the patients. These all, the infants, incidence of ROP in different regions of India across has been reported, the range of 38 to 47%. In our study, stage 1 ROP was seen in 50.5% patients. In stage 2 was seen in 31.9% patients. And in 6% patients, stage 3 was reported. And 2% were presented with stage 4, and 1.5% were presented with stage 5. And aggressive ROP was seen in 6.9% patients. Out of 188 infants who were detected for ROP, out of 188 patients who were detected for ROP, 29 patients out of 188 infants who were detected for ROP, 71.2% they regressed spontaneously, and 27.6% infants they were subjected for intravitreal injection, and 2.12% infants they were referred for vitreoretinal surgery for higher center. And also the infants who received intravitreal injections, they were followed up according to ICROP guidelines, and out of them 94.3% infants they showed ROP regression, while 5% infants they were lost to follow-up. So I would like to conclude by saying that a recent change in Indian guidelines warrants the screening of all infants with a birth weight of less than 2,000 grams and gestational age of less than 34 weeks, which should be done within the first 4 weeks of birth with an earlier screening in infants which were born before 28 weeks or lighter babies less than 1,200 grams. Usually to be done within first 2 to 3 weeks of life. And all the infants which were treated with anti-VEGF injections, they showed regression, and recurrence was not seen in most of the cases, which establishes the role of management of ROP with anti-VEGF injections. And also, due to advent of improvement in quality of neonatal care and expanding ROP screening devices and increasing awareness about the risk factor, there has been early detection of preterm infants and hence decrease in burden of childhood blindness. These are my references. Thank you, ma'am.
Nice presentation, Dr. Garima. Would like to, after seeing the incidences in the Northeast India, so would like to highlight about the screening programming, more of screening for the ROP child.
Yes,
need to mobile screenings that should be happening. So to detect the baby in early stages, to intervene early, and to further preventing that baby going into 4 and 5 stages. So for that, what we can do is in pediatric setup itself, we need to tell the pediatric or neonatologist to tell the parents properly about the condition of the child, because they don't know the baby outside, it will be in a low weight and they will be more concerned about the weight gain and the general condition of the baby, but they might ignore the eye changes which are happening to the baby. The parents also might not be aware. By the time they are aware of the condition, the baby might have lost her vision as well. And the parents also at that time later on, they might blame the pediatrics, neurologist and the ophthalmologist. So that should be highlighted in the screening thing, or else like that, to reduce the burden or incidence.
Yes, ma'am.
Nice presentation.
Thank you, ma'am.
Next speaker for today's e-poster session is Dr. Shruti Vade. She'll be talking on ocular firecracker injuries during Deepavali. Over to you, Dr. Shruti.
Good morning, everyone. My topic for today is pediatric ocular firecracker injuries. The purpose of this study is to delve deeper into 2 cases recorded during Deepavali who availed the emergency eye care services of our center to highlight the role of firecrackers as a case of ocular injuries in firecracker lighters and innocent bystanders as well. This poster intends to call attention to the preventive measures, safety guidelines, and effective treatments to reduce the occurrence and severity of such injuries, ultimately improving public safety during festive events involving fireworks. In the methodology, we are going to talk about 2 patients. A 8-year-old male who presented with the complaints of redness and pain, and a 13-year-old male who presented with the complaints of loss of vision in right eye, redness, bleeding, and pain. In the first patient, he was hurt during a neighborhood firecracker display, and in the right eye, during examination, we found out that the visual acuity of the patient was counting fingers close to face, PL positive, PR accurate. There was edema in his lids, congestion in the conjunctiva. The cornea was stain positive. There were few epidefects. AC had a normal depth in the iris. There was iridodialysis at 7 to 10 o'clock position, right here. In the pupils were dilated and fixed, the lens was clear, and in the fundus there was a dull glow with hemorrhages over the disc and macula. The left eye was within normal limits. In the second patient, he was also hurt during a firework display and was also an innocent bystander. In the right eye, he presented with a vision of PL positive, PR inaccurate, lids were normal, there was congestion in the conjunctiva, and the cornea had a 10 to 12 mm full thickness corneal tear. The AC had total iphema. Iris we saw a uveal tissue prolapse. The pupil, lens, and fundus had no view. The left eye was WNL. This is the second case. We can see a 10 to 12 mm full thickness corneal tear, and there was uveal tissue prolapse as well. This patient presented with a vision of PL positive and PR inaccurate. In results, we can see that in the first patient and the second patient, we did a CT brain plus orbit, and the results were that in the first patient, there was a mild preseptal edema, and in the second patient, there was no evidence of intraocular foreign body, and a corneoscleral tear repair was done. And we started a topical management for both the patients. In the first patient, the patient was managed conservatively, and the second patient, after the tear repair, we managed the patient conservatively. In conclusion, I would like to say that firework-related ocular trauma is one of the major preventable causes of ocular morbidity and blindness in children and young adults, in both active firecracker burners and innocent bystanders during festive season, and hence represents a significant public health concern. Understanding these unique challenges associated with ocular firecracker injuries is crucial for developing effective strategies to reduce the incidence and mitigate long-term visual consequences. Awareness among the masses, preventive measures, and strict implementation of government legislation may help in bringing down the incidence of firework-related ocular morbidity and blindness. This is the take-home message for fireworks safety. We can keep a bucket of water or garden hose nearby in case of fire. Wear safety goggles available in the optical shop. Never let children play with fireworks unless they are supervised by adults. And don't pick up fireworks after they have been lit. And notify any veterans in your neighborhood if fireworks are going to be used. And enjoy professional firework presentations and avoid doing them by yourself. If the eye has been damaged, we can follow these measures. It is important to not rub the eyes as it may worsen the injury. Do not apply pressure to the eye. Do not apply any ointments or pain medications by yourself. Do not remove any objects from the eye. These are my references. Thank you.
Thank you, Dr. Shruti. Nice presentation, and when the Deepavali is nearing now. So, how the child later on presented, like how was the fundus, or was it seen on B scan? How was the
Yes, ma'am. Ma'am, in the first patient, the child was pretty normal. After he came, the vision came back to 6/12 parts, and after refraction,
the posterior segment was not involved.
No, ma'am. The posterior segment was not involved in the first patient. Ma'am, in the second patient also, the fundus was clear, but in the anterior segment, ma'am, there was corneal opacity. The vision came to counting fingers at 2 meters, ma'am. PL was positive, PR was inaccurate because it was in the
2 meter was the final vision.
Yes,
was the lens was injured? Anything?
Ma'am, he developed a traumatic cataract. We had to replace the IOL for the patient.
Fine, thank you.
Thank you, ma'am.
Any other presenters for today? Okay. Good morning, everyone. Myself, Dr. Tejaswini. I'll be presenting about a kind of a new innovative method we have done in our hospital on it called topical application of glycerol in ophthalmology procedures. So, basically, we know that corneal edema is nothing but a loss of transparency due to the accumulation of fluid in the corneal layers like epithelium and stroma, resulting in loss of transparency and causing blurred vision to the patient, and also causing a fundus visualization difficulty for the ophthalmic examination as well. So to clear the corneal edema, there are various mechanisms. One of the thing is usage of hypertonic agents like glycerol. We know that hypersol eye drops. But for the instantaneously clearing the corneal edema, we can use the glycerol. the methodology of the aim of the study, to study the efficacy of the topical application of glycerol in corneal edema. We did it's a prospective case series study. We did it on 31 patients who presented with corneal edema, where we used 3 to 4 drops of topical glycerol in their eyes, and instantaneously the corneal edema has resolved within 3 to 4 minutes, which in 30 seconds to 2 minutes, and so the cornea became clear, and we could able to see the fundus and do the further examinations. Inclusion criteria is like patients having corneal edema, and exclusion is patients having the clear cornea. Obviously, when there is a clear cornea, we don't need to put any hypertonic agent. And the patients having any corneal epithelial defect and any scarred corneas, these were excluded. So I'll be presenting this in 5 scenarios. The first scenario, in this, you can see in the picture in the left side, where you can see the cornea, POD1, the post-cataract surgery, to the complicated cataract surgery, the cornea was edematous and the loss of corneal transparency was there. In the post-day 1, what we did was we put a topical glycerol eye drops. The corneal edema instantaneously reduced, and we could able to see the descemet membrane detachment, highlighted with the yellow arrow. So further evaluation of descemet membrane detachment can be done in the POD day 1 itself, so that we can give quickly management with the air injection can be done. So further delay of the treatment won't be happening. In scenario 2, where it was again a complicated cataract surgery, where the anterior subluxation of IOL happened, and the haptic of the IOL was rubbing the corneal endothelium, and corneal edema was happening, so obscuring the further details. So we kept in the right side of the slide, you can see we kept the topical glycerol eye drops. The cornea slightly clarity has come, and we can see just extra details like other than haptic touching the endothelium, we can see the crumpled bag and the retained cortex in the end vitreous as well. And scenario 3, patient presented with pain, redness, and corneal edema in the left side. And when we saw for the fundus examination, nothing was seen except a kind of mild haze of the disc. Nothing details were seen. So after instilling the glycerol eye drops, the corneal, you can see in the right side, the cornea became clear, and also slightly we can see the fundus as well, where we can see the pale disc, sclerosed vessels, and a hemorrhage kind of picture. So we came to a diagnosis in which the higher pressures are due to the CRVO. So by putting the topical just glycerol eye drops, we can further manage within the OPD, further not delaying the diagnosis and the treatment. That was a scenario 3. Coming to the scenario 4, it was a case of NVG, where the patient again had a corneal edema because of the raised pressures. In an NVG case, we knew that we need to do pan-retinal photocoagulation as early as possible. So when the clarity of cornea is not there itself, we will be delaying the treatment. So we can put the topical glycerol there, and in the OPD itself, the cornea gets cleared, fundus can be seen, and so that we can give a sitting of PRP. So the delay of treatment won't be there. In a vitreoretinal surgery, I'm a vitreoretinal specialist, so where we had to have a proper visualization of the posterior segment. So when there is a cornea edema, we can't further proceed for the surgeries. So what we can do is intraoperatively also, we can put a 1 or 2 drops of glycerol, and the cornea gets cleared, and further we can proceed for the surgeries. This is one of the another use of topical glycerol. So coming to the discussion, hypertonic agents they usually increase osmolarity of the tear and draws out of the fluid from the cornea. And scraping of the corneal epithelium also can be done, but further it causes infection. So because glycerol is just a clearless liquid with a specific gravity of 1.26, a molecular weight of 92, it's a trihydric alcohol. Previously, it was used just to reduce the corneal edema in a case of bullous keratopathy. But what we have done in our studies, we can use it for the diagnostic and of the treatment-wise purposes. So it's a topical glycerol comes as an immediate rescue, especially in the managing conditions like descemet membrane detachment detection and allowing further treatment. And in cases like neovascular glaucoma with corneal edema due to raised IOP, which needs prompt PRP, where delaying of PRP due to corneal haze further leads to increase in VEGF drive, NVA, NVA, and rise in IOP, and this becomes a vicious cycle. And the patient might lose vision as well. So topical glycerol helps us in a quick management. So topical glycerol application is in ophthalmic procedures an innovative approach for regular practice, which is a cost-effective, safe, and instant outpatient or intraoperative procedure, facilitating better visualization for diagnosis and therapeutic purpose as well. Thank you. solution only